1 second. Just make sure I get the schedule right here. So it really gives me great pleasure. I think this is one of the highlights of the year, our Student Innovator Award. And just a reminder that the award recognizes Rick Bay, who was one of the founders of Jobson, one of the leading publishers for optometry and ophthalmology. And this is the Rick Bay Foundation for Excellence in Eye Care Education. That foundation funds this innovation, not funds, it sponsors this innovation award. And we're very, very lucky to have partnered with VSP, who have sponsored this for several years now. The winner, as a reminder, gets a $5,000 scholarship. Normally, they would also get the opportunity to fly to New York and present their idea at Vision Expo East and associated meetings there. That will happen hopefully virtually, but sorry that that meeting won't be live this year. So without further ado, and with, again, special welcome and thank you to Vernon and Ron, who are here from VSP for their sponsorship. The first, or actually, I should probably just say what the process is. There's judges here tonight. So we've got Dr. Teresa Petussery, Dr. Jorge Quadros, Dr. Austin Rueda, and myself as the judges. And we will be looking at originality, impact, viability, and feasibility. So they're the criteria that we're judging each of these presentations by.
Dr. Flanagan, not to interrupt either, but we also have Dr. Garrett Smith, who is one of the judges as well. He is on with us now.
Sorry, Garrett. Welcome. Thank you very much.
No problem. Thank you.
So we will get each of the contestants will present, and then the finalists will present, and then the judges will go into a little breakout room for a few minutes, and then we'll announce the winners. So the first presenter tonight is Peter G, and his project is titled Auto Lens Trial. So off you go, Peter.
Thank you, Dean Flanagan. All right, can everyone see my screen? Awesome. Well, good evening, everyone. I am really thrilled to be here. Thank you for this amazing opportunity for me to share my proposal with you tonight. I hope in the next 10 minutes, I will make a case on why I believe the auto trial lens demo should be the next step forward in optometric innovative technologies. And starting off, we understand that for any optometrist, demonstrating prescription is a vital part in determining what ends up in the patient's glasses and whether or not a lens redo will be coming back to the office. Making sure that a lens demonstration is done accurately and efficiently should be the goal of every successful optometry practice. And the current demonstration method involves nearly 300 pieces of trial lenses with a bulky trial frame for the patient to experience the new prescription. And not only does it take a valuable time for the doctor to assemble each trial lens demonstration, the presbyopic and the binocular vision patients who require meticulous assessment will often have to go through multiple rounds of demonstration before finding the right amount of add and prism in combination with the prescription. According to an article in 2018 from the Review of Optometric Business, 30% of lens redos are due to progressive second height changes, 20% are due to doctor's changes, and 10% are due to patient dissatisfaction with the glasses. That's a total of 60% of lens redo over which optometrists could influence during their eye exam and would easily save the practice tens and thousands of dollars annually if it's addressed. Not to mention all the time spent by the doctors the staff members who have handled these redo cases, and the potential loss of returning patients and referrals in the future. So the goal of my project here is I believe that the challenges that I just presented could be just addressed with an automated trial lens demonstration technology. Such a technology would significantly reduce the amount of time needed to set up for the demonstration, and it will provide a more realistic demonstration for the patients by using a trial frame that resembles a real pair of glasses and reduce the number of redos and patient dissatisfaction. Here are some of the key topics I'll be discussing regarding my project, and in order to make this overview brief but comprehensive, I'm going to skip over some of the specific technical aspects involved, but I'll be more than happy to discuss them in detail in Q&A if anyone's actually interested. Before I begin though, it has been literally 1 decade since I took my drafting class in high school, and this is my first time making the effort to draw anything in 10 years. So please excuse some of the primitive drawing you may see throughout this presentation. Without further ado, moving on to the control panel. So this is where going to be all the data input take place. The prescription information and the trial frame setting will be entered via the keyboard, and the digital display will show the design and setting of the trial frame. It will be connected to the EMR of the private practice and it's able to take in specific setting for each particular patient based on the previous exam records. And what I eventually hope to achieve is to allow this control panel to communicate with other advanced optometric equipment, such as the auto lensometer and the autophoropter. This means that as soon as the doctor has done the refraction, all the new prescription data will be immediately transferred to the auto lens demo, and the assembly process will begin immediately. And in some cases, could finish before the patient is taken out of the phoropter. Next up, we have the new trial frame. And unlike the current trial frame, this one will not have any of the knobs that's made for manual adjustments. All the data regarding the patient pupillary distance, the panoscopic tilt, temporal length, and segment height will be entered via the control panel. And after receiving the trial frame, the trial lens, the lens assembly unit, which is going to be coming up next, will make the adjustments to the trial frame for the patient. And these changes will allow the trial frame to be much lighter, less bulky, and is able to resemble an actual pair of glasses. And this gives the patient a much more comfortable and realistic experience when wearing the new prescription. The lens holder right now can hold up to 5 lenses, including the prism and add. And the add lens will always be at a particular lens holder position, which could be adjusted for segment height changes if necessary. Next up, we have the new set of trial lenses. These trial lenses has a red attachment semicircular ring, which will roll from the lens holder in one section of the unit to another, and this is how the transfer will take place across the different parts of the device. In total, we're going to have 40 sphere lenses, that includes plus and minus lenses, 18 cylinder lenses, 16 add lenses, and 20 prism lenses, for a total of 94 different lenses. This is nearly 1/3 of the total number of lenses in a traditional trial lens set. And I chose these numbers specifically because when I went through them in detail, I was pretty much able to create most combinations of refractive errors from quarter diopter all the way up to 22 diopters within 5 lenses or less. Moving on to the lens assembly unit, this is going to be where the most challenging part of the design comes in. So the 94 trial lenses, as we discussed, will be distributed across 8 different stacks. Each will be held in place by a lens holder similar to that on the trial frame. And we're going to have 4 sets of plus and minus sphere lenses at the back, 2 sets of cylinder lenses on each side, and 2 sets of add lenses along with the prisms stacked on top of each other towards the front. And each side will have what I call an automated retractable manus, or the arm, to maneuver through the assembly unit and retrieve the lenses and deliver them to the trial frame. And the process to deliver lenses will take place as follows. The arm will retrieve the lenses from the lens holder inside the lens assembly unit and approach the trial frame, as you can see in step 1. It will dock onto the trial frame's lens holder section and push the attachment ring in a circle such that it would rotate through from the arm to the trial frame. And this is where essentially the attachment point of the trial lens will be shifted from one section to the other. Afterwards, the lens could be removed along with the trial frame for demonstration purposes. And if changes need to be made, just insert the trial frame back into the machine, and this process will occur in reverse as arm works to remove the current lens and bring new ones back in for the demonstration. And basically some of the key improvements with these changes, we're going to have a faster and more accurate demonstration, which has improved exam efficiency. The trial frame will include the adjustment segment height, which is something that's not available in the current demonstration process. We're going to have a more comfortable and more realistic demonstration, which improves patient experience. And there's essentially going to be less tedious work for the optometrists too. We're going to have an improved doctor experience in the process. The doctors can just assemble and change the prescription without manually inserting and removing individual trial lenses. I've broken up the development plan for this project into 4 different stages. Stage 1 will be to create the prototype of the proposed device with some of the fundamental features. And this will include the arm with the basic functions like retrieving and transferring different trial lenses, along with compatible trial frame and trial lenses in the process. Stage 2 involves some of the advanced features, like including making the arm able to maneuver laterally and vertically into the machine, and fine-tune the retractable features such that it is able to grab multiple lenses at once, and including the segment height changes and the trial frame as well. Software integration will begin in stage 3 with the goal to allow the device to communicate with other technologies like the EMR and other optometry equipment like the autolensometer and autophoropter. By the time we get to stage 4, we'll hopefully have a fully functional unit available, and my plan is to make this available to specialty practices, collect their feedback, and make necessary improvements before we make them publicly widely available to general private practice. And when a new feature eventually gets developed, we will essentially go back to stage 1 and repeat 2, 3, and 4 again until the new feature is incorporated into the final product once more. This is a timeline I have developed for the next 1.5 years for this project. After the Student Innovator presentation, hopefully I will have the opportunity to bring this project to Vision Monday Leadership Summit in March. And by June 2021 this year, my goal will be to draft up a patent protection proposal for this project. Not sure exactly how long that's going to take. I'm projecting 6 months, but that could vary significantly once I look into it a little bit deeper. But hopefully I will have the project team recruitment process begin 1 year from now in January 2022. And we will immediately work on the official prototype design and ideally have it complete by March that same year, and followed by some additional funding proposals, and the plan to start creating a new functional prototype will begin in June 2022, exactly 1 year and 6 months from today. And so before closely wrapping this up here, just the summary of what we just talked about, not only is the manually assembly the trial lens demonstration subject to human error, and it consumes valuable time in an eye exam when multiple demonstrations have to be made and could lead to patient frustration. Compared to the traditional trial lens kit, the proposed device will provide a lighter and less bulky trial frame. It will reduce the time needed to spend on assembly and adjusting the trial frame, and improve the overall patient experience and doctor's experience with faster and more precise demonstration. And I strongly believe that, much like the autolensometer and autophoropter, the auto trial lens demo will be a substantial advancement in a realm of innovative optometric technology, transform the perception of optometry in the eyes of patients, industry professionals, and fellow healthcare providers. And before we wrap things up, I would just like to give a quick acknowledgement to Dr. Carol Hung, Dr. Dennis Fung, Dr. George Lee for their valuable and informative feedback for me over the course of planning this project. And with that, I'd like to thank all of you for your time, and I'll be happy to answer any questions.
Wonderful. Thank you very much, Peter. Annie, if you're there, if we can just go back to or stop sharing Peter's screen. So we will first take questions from the judges, but I'm just going to take this opportunity because I didn't really introduce him properly, that we are joined by Dr. Garrett Smith. And Garrett is the innovation principal for the VSP Innovation Center. So again, thank you for joining us, Garrett. So we'll have questions from the judges first, and then we'll throw it open to questions from the audience. And if you could perhaps let me know in chat whether you want to ask a question or raise a hand, and I'll see if I can find you. So judges, questions. And Peter, I thought your drawings were great, by the way. So,
I appreciate it. Thank you.
Austin.
All right, thanks. Thanks, Peter. Nice presentation. A couple questions. So I'm not a real doctor, so I have some questions about what the process is that involve the trial frame, the current trial frame assemblies that are used. And so it looks like some of the adjustments are sort of baked in, which has that advantage that the optometrist doesn't have to futz around with it. But what do you know about the experience of optometrists in making micro adjustments to the lenses in the trial frames, the existing technology, and how important those small adjustments like pantoscopic tilt and maybe the orientation of the astigmatic lenses, how important it is to have the ability to make those adjustments once they have those lenses in place? And would you be giving that up with your technology?
Well, that's a great question, Dr. Rhoda. My initial idea would be that this would essentially reduce the need for any of those manual adjustments and make the trial frame less bulky and more resembling of real glasses. And at first glance, it may seem like I am giving that up, but I believe that it's definitely possible to still include the ability to manually make adjustments. Nose pad is one of the examples where I will not be, it's not possible to be automatically adjusted. So that is something that can still be adjusted by the optometrist. And you bring up a really good point, as these small changes that you mentioned, such as pantoscopic tilt and cylinder adjustments, should be left untouched and left available for optometrists. I do think the cylinder, though, could potentially be incorporated into the design such that it's done automatically and more efficiently than if you do a manual adjustment. Pantoscopic tilt, same thing. Ideally, you should be able to make that setup on the machine and make changes where necessary without taking up too much time. But I do think the overall trade-off in getting rid of some of these manual adjustments will be a more efficient and more realistic demonstration for the patients.
Thank you.
Any other questions from judges? Peter, at one point, I think you said that the selection of lenses, you could process most corrections, but I believe you said that up to 4 or 5 lenses might be needed. How do you compensate for multiple lenses, vertex distance, all those sort of problems that would bring? Right. So in terms of the spherical lenses that I have, I've written down here, it's not on the presentation, but for example, I'm not going to have a plus or minus 3 diopter sphere lenses. And if say a patient needs, for example, a minus 3.75 diopter prescription, for example, then we're just going to take a minus 4 lens and a plus quarter lens in order to make that adjustment, so that we don't have to use that many lenses where not necessary. And in terms of vertex distance, I do not have a good solution for that. I think that's just an unavoidable problem with lens demo and the current technology. But every other aspect should be improved from the current demonstration method. I hope that answers the question. I can elaborate a lot more if you want to know. Okay, thank you.
Okay. Yeah, just a quick question. Will you be able to do an over refraction with this as well? I mean, are the frames going to be able to fit in front of an existing pair of glasses? So
I guess that is a valid trade-off then. You probably won't be able to, because if this lens is meant to resemble that of a real pair of glasses, it's probably not going to be available to do over refraction. However, I do think that if you were, now that I think about it, you could potentially remove the temple from this new pair of trial lenses and just have it become a lens holder, essentially, handheld trial frame. So that could potentially become an option.
Teresa, did you have a question?
So Peter, you mentioned initially that you'd like to deploy this in specialty practices. Do you have a sense, in the long run, of the cost and whether this might be something you could, implement more broadly than that?
Yeah, so the reason why I chose specialty practice as the first step in distributing this device is, I personally believe that, and from talking to Dr. Hong, there is a particular need in specialty classes such as binocular vision, where pretty much every single patient you see requires a meticulous adjustment to the prism, and every other small detail does make a huge difference for the patient experience. So I do believe that by implementing them into specialty practice, that's going to fill a demand that's currently in need. Once that becomes widely available, when the demand goes up, I think it will be naturally cheaper. When this becomes more widely used, it will become cheaper for private practice to implement into their own system afterwards. So that's why I chose that route.
Thank you.
I think Teresa just asked my question, but I was curious what you think the biggest barrier to adoption will be to the specialty.
Adoption for practice or for the patient?
Both.
Ideally, there wouldn't be an adoption, or there will be less an adopted issue for patients specifically, because if done successfully, this should feel like just a regular pair of glasses. I guess the problem will be it's not their own glasses that they're used to. So it should technically be better than the current trial frame demonstration method that the patient would experience in every private practice. For the practice itself, though, I believe initially it may be a little bit of work to try to incorporate this into everything else, hardware-wise and software-wise. But once it does become implemented, I strongly believe that, just like I said, just like the autolensometer and the autophoropter are cornerstones in some of the current practice, I do believe this has a lot of potential to become a strong, a fundamental aspect in terms of any optometric practice in the future.
Thanks.
Okay, I'm going to throw it open to the audience. Any questions? There's nothing in the chat so far. Looking for hands. Dr. Corzine.
Unmute. I just have a question about segment height, because segment height is specific to the frame that the person chooses. So how do you determine segment height with this trial frame?
I'm glad you asked that question. So what I have in mind is it's going to be relative to the PRP of the patient. I didn't include that because that would just make this presentation 20 minutes long. But what I have in mind is the patient will wear the frame at first. We're going to calibrate where their eyes are going to be relative to the frame. And we're going to make the segment height relative to that part. And then relative to wherever where the eyes are going to be relative to the lens is going to be the calculation that's needed for the final prescription product. So the segment height that we use for the trial frame is not necessarily going to be the same distance as that on the actual frame. It's actually relative to the PRP of the patient.
So you'll have a way to transfer that to the frame that the person has chosen, their actual frame.
Depending on the actual frame, I think that will be doable for sure, yes.
Okay, thank you.
Any other questions? Well, Peter, thank you very much. That was a wonderful presentation. You got us off to a good start there. Thank you.
It was my pleasure. Thank you so much.
Lots of virtual clapping going on. Our next contestant and their 10-minute presentation is Young Kim, biodegradable film coated scleral lens for drug delivery.
Sorry, just let me, I don't know what to do with this Zoom little thing at the top. I guess I'll just have to have it at the top edge. But okay, I'll just start off. As you can see from this character here, he's obviously having a difficult time putting his topical eye drop into his eye. And I think this illustration actually very well summarizes the rationale behind the innovation idea that I'm going to propose today. And to be quite frankly, the issue that this patient or this subject is having is not just unique to this illustrated character. In fact, oh, sorry, the slide's not work. Okay, sorry. Okay, cohort studies found that approximately 54 to 59% of the study populations are actually not compliant with their topical glaucoma medication. Common issues being patients just forget to administer the drug, especially if it has to be administered multiple times during the day. And another issue is that they blink eyes like this character, and they end up putting less amount of dosage in the eye, or because of that fact, they overcompensate by putting another drop in the eye, which results in overdosage. These issues can lead to ineffective treatment because of the not adequate dosage of the drug, and could also lead to stinging redness or irritation in the ocular surface. Also, for contact lens wearers, if they have to put multiple drops into their eye, they have to take the lens off during the midday, put the drug in, wait, and then put the lens back on, which is very encumbersome. And let's say you're still compliant and you're the minority of people that are truly compliant with these topical eye drops. 90% of these topical drops are actually washed out into your punctum while you're blinking your eye. Therefore, my innovative idea is to create a biodegradable film that is adhered to the scleral lens to deliver drug to overcome these issues. So when I had this idea, the first thing I did was, of course, see the literature and see if there were drug delivering soft contact lenses or any type of contact lenses that are available commercially. Turns out there's been over 30 years of research on the drug delivering contact lenses. but there's been no commercially available product available. So I researched deeply into why that might be the case. And turns out the biggest issue that's preventing commercially available drug delivering contact lenses due to the lack of control of how much drug is being released from the lens to the ocular surface. And that can be shown in this example from this group that's done the research. Basically, y-axis shows the amount of drug release, x-axis is the time it takes. And you can see at the beginning, the moment that you put the contact lens on, large dosage of the drug is released from the lens to the ocular surface. And then the rate that the drug gets released changes over time. And this initial bulk release is due to the concentration difference between the drug in the lens and in the eye, which is none. And the concentration gradient results in the large amount of drug being diffused out of the lens into the ocular surface. This uncontrollable burst release is the main reason why there are no commercially available drug delivering soft contact lenses. Therefore, going into my innovative idea, which is to create drug delivery scleral lenses using PLGA film on scleral lenses. Sorry, I can't pronounce that word sometimes. But just to give a basic background, scleral lenses are lenses with large diameter, rigid hard lenses that have about 16 to 20 millimeter lenses. And my proposal would actually allow you to use any type of scleral lenses that you want to. And the innovative part now comes in this adhesive drug containing PLGA film, which is about 1 millimeter wide or thick, whichever you want to call it. And the PAGL film contains drug particles embedded in this thing, in the film, sorry. And the reason why I chose PLGA is, of course, it's biodegradable. And it actually is already FDA approved to be used in clinical, to be used as a treatment. And I believe there are drugs that are used to implement implants in the vitreous humor for drug treatment already using the PLGA. So basically what you do is you simply adhere the PLGA on the lens posterior surface. And this is easily done by using this PLGA stent. And basically this is a stent that will have the number of strips that are actually PLGA strips in this circular region. And when you press a button, the one of the PLGA strips just comes up to the top, and with the adhesive side being on the top. And all you have to do is put the lens and put the lens down, and the adhesive PLGA film will attach itself to the scleral lens. Once you've done that, you just wear the scleral lens as you would with a normal scleral lens. So how the drug actually gets released is the question that of interest. So upon putting the lens on, you see this gray area, which is the PLGA, and then the yellow drug molecules that are embedded within the PLGA. And of course, because you inserted a lens, now the PLGA is interacting with the tear that is between the contact lens and the ocular surface, which is the post-lens tear film. So throughout the lens wear, what happens is the PLGA dissolves, biodegrades, which means that the drug molecules that were embedded within the PLGA are now free and are released to the post-lens tear film. And the diffusion occurs, and the drug will eventually reach the ocular surface and give the treatment to the eye. So the most important thing about this method is that it results in constant drug release rate. And that was shown from Ross et al. In the Biomaterials 2018, where the y-axis is the percentage of drug release, x-axis is time, and the line that I shown with the arrow is the PLGA drug release mechanism. As you can see, this PLGA with drugs embedded in them can release drug at a constant rate for over 60 hours. So simply, the patients just have to wear this in the morning, wear for 8 hours, take it off, clean the lens off, and rinse and repeat, and you'll get a continuous release of drug to the ocular surface. So the benefits of these drug delivery scleral lenses over available topical drops are, of course, number one, is better user compliance. No more missing those drops when you're trying to put the drops in. And also, this allows continual low dosage of drug release to the ocular surface, which is actually a very new concept. And it could be very beneficial to drugs such as steroid, where traditionally we kind of have to wean out the steroid dosage at the end to make sure that the eyes recover properly. However, with this, we can just do low dosage and ensure that we don't have to go through that cumbersome step. Another benefit is that these can control drug release to patients' specific needs to eliminate over or under dosage. And lens drug is drained out of the punctum a lot less with scleral lens wear because the post-lens tear film is isolated from rest of the tear. And this results in less amount of drug getting absorbed by the nasal mucosa, which means less drug entered into our system. Of course, no need to worry about midday contact lens removal to put administer the drug because you're already wearing a lens that's delivering the drug. So comparing this with now to proposed delivery soft contact lenses that are in the literature today, first, the proposal that I have can control how much drug is released, unlike the proposed soft contact lenses that are available in the literature. Also, drug will likely distribute more evenly on the corneal surface due to the thick post-lens tear film scleral lens, but not for the soft contact lens. And this is because the post-lens tear film thickness allows enough space for diffusion to happen. So one of the bigger concerns with soft contact lens would be that most of the drug release would actually interact with the corneal surface or the ocular surface that where the drug is being released to, whereas that's not an issue for scleral lenses. And PLGA drug release films have been studied extensively and is not difficult to formulate. So taking that technology and implementing it to drug delivery scleral lens would not take that much of a significant effort of biological studies and kinetics, chemical kinetics. And PLGA films are unfortunately not feasible with soft contact lenses because soft contact lenses need to be hydrated all the time, which makes it difficult for the lens to adhere, or for the PLGA film to adhere to the lens surface. And finally, the drug delivery with soft contact lenses may result in lower visual acuity. So because the lens diameters are so small and the drug may potentially be loaded in the optical zone of the lens. So basically, my proposed idea introduces a novel way to provide any type of topical drugs to the eye more effectively. So of course, there's need to be a plan to actually formulate this idea into a real product. And to do that, the first thing that we really need to investigate is to determine the safe drugs release rate, how much drugs should be released for effective and safe treatment using this novel method. And to do that, we actually need to have a better understanding of how the post-lens tear film fluid dynamics works on drug delivery to the ocular surface, because we don't really know what's happening within the post-lens tear film fluid within during scleral lens wear. So because of that, I've actually done some preliminary computational analysis that determines if there could be a circulation that exists in there that could further help diffusion to help deliver drug from the periphery to the rest of the cornea. And turns out, because of the high temperature gradient that exists between the cornea and the environment, there's a temperature gradient within the post-lens tear film that allows buoyancy-driven convection. Like when you boil a water, the water convects from hot to cold. Microcirculation cannot happen in the post-lens tear film. This, of course, needs to be studied further. And of course, we need to determine the ideal drug concentration that should be embedded in the PLGA for optimal treatment of different types of diseases. And after all that analysis has been done, of course, we need to develop a PLGA film following the available literature to conduct animal studies to assess effectiveness and safety in vivo. Once all of these steps are done, prototype for clinical study can be made to study effectiveness, safety, such as lens wear hypoxia, and comfort. So of course, the aim is to focus on one specific drug at a time so that I have a workable prototype in a realistic time manner. To conclude, I've introduced the novel system that can deliver virtually any type of drugs to the ocular surface. And this will be more effective, safe, and controlled way to deliver topical drugs to the eye, and will likely lead to higher compliance and less drug concentration exposed to the body, which is always a plus. And provides also a way to deliver low dosage of drug continuously to the ocular surface for potentially new way to treat diseases with lower continuous dosage provided to the eye. Drug-loaded PLGA films are already manufacturable, and PLGA is already approved by the FDA for human usage. So that cuts down a significant amount of time to be able to get this product out into the market and to be tested clinically. And this will be easy to use by patients. Simply push the lens onto the PLGA stand and wear. And then once you're done wearing it, wash it, and then clean it, wash it, and the next day put on another film and until your doctor tells you to stop. And of course, like I said, we need to determine the ideal dosage for various types of ocular treatments. And we also need to study the effect of post-lens tear film tear dynamics on drug delivery, as I mentioned in the previous slide. And this was an idea because I realized that scleral lenses can be expensive, but for people that are having temporary treatments, there could be a system implemented where patients can simply borrow lenses from the clinic and just buy the PLGA film and wear the lenses until they're done with the drugs and simply return this lens back to the clinic, which would save patients a significant amount of money and would be, I think it would be a very beneficial way to provide treatment to patients using this method. And thank you, that's all for me.
Thank you, Young. Judges, questions?
So I'm curious, I can see the benefits from a platform technology perspective for multiple applications, but could you speak to your focus on glaucoma compared with other disease states?
Can I compare what with the glaucoma? Sorry, I missed the last part.
Yeah, so just you mentioned glaucoma as a focus area, but this is also a platform technology. So I'm just wondering if you could speak to why you chose glaucoma, or are you open to other types of clinical applications?
Oh, definitely. I'm open for other clinical applications, but the reason why I focused on glaucoma is because I can't study all different types of drugs and try to optimize all of them at once. And glaucoma is one of the leading causes of causing blindness. So I felt like, and a lot of the treatments for glaucoma is to use these eye drops to treat it right now. So I felt that would be the most beneficial area to tackle first for the benefit of the society.
Thank you.
Jorge.
Yeah, Young, that's a great idea. And you know, when you look at the literature, it does show that there's been many attempts with contact lenses to deliver drugs. And it seems like there's also been some with hard contact lenses that are PLGA coated, drug-eluting contact lenses. You know, and in PubMed, you can see these articles. Is the innovation here because it's a scleral lens, or what's the difference?
So there are actually multiple differences with this. With soft contact lenses, I talked about the kinetics and difficulty using the PLGA. With GP lenses, you actually get a lot of these movements and small interaction between the friction, between the lens. So you can't really put these adhesives on the lens without bothering your eye, especially with regular GP lenses. They're such a small diameter that they could actually potentially scratch your cornea. Whereas with scleral lenses, you get this large diameter that's barely able to move during the inner blink period, which allows for things to be quite convenient. And that's part of the reason why the scleral lens is used, and it definitely doesn't occlude the ocular vision. And I don't think I've read studies that read about impregnating GP lenses. I've only read that about soft contact lenses, but delivery kinetics using embedding the GP lenses would be very difficult, I imagine, because GP lenses are hard lenses, and you're not going to get drug to readily diffuse along with hydration, water content, like in the soft contact lens. So I just felt like GP lenses would be difficult to implement this idea to be feasible and realistic to use by patients, and safety as well.
Great, thanks.
Teresa?
Young, so many glaucoma patients are elderly, they're presbyopic, their manual dexterity might be an issue. Do you think this will be easier for them than getting the drops in the eye?
So I think the idea here is that, yes, I agree that people with presbyopia would have a hard time wearing contact lenses like this to begin with. But I think there's also been a huge increase in myopia population over time. And I think those people would actually benefit from these type of mechanism, whereas compared to having to take the lenses off and putting drops in for certain type of situations and etc. So I think having this alternative would be a very good thing, you know, generation where myopia is becoming out of control pretty much.
And then one more quick question, sorry, about reattaching the film each day. So the lenses presumably need to be completely dry before you can attach the film?
So, right, so adhesive, I'm sure there are other adhesives that can attach when it's wet, but ideally having a dry surface is ideal. And when I wore scroll lenses, I was actually able to keep the scroll lens dry overnight and then just clean it out before I use it and then dry it. And then I can just put the film on and then put it in my eyes. So I think that worked out pretty well.
Thanks, Jan.
Yeah.
Austin.
Nice presentation.
Thank you.
So have you done what fraction of people are willing to use scleral lenses? Is there a problem with acceptance of using this type of lens? Teresa did mention that they're kind of difficult to take in and out.
Yeah,
What
I
would
think
be a real
that's
barrier to.
right. I think that's a very good question. I mean, the resurgence of these lenses have been fairly recent, about 10 years, if that, just because of the material capabilities. But I don't know how many people will be willing to switch over. But based on my personal experience with these lenses, I've seen that when a lot of the soft contact lens wearers, when they try wearing a scleral lens, they actually find it more comforting because you have this fat reservoir in front of the eye that keeps the eye from dehydrating. So I've actually seen quite a few soft contact lens wearers that were not able to wear lenses for a long time, wear these lenses over 7-8 hours without any issues.
Quick question from me. It's a ring of the material.
Yes.
And you said it was about 1 millimeter
Yes.
deep.
Oh, sorry. I meant to say millimeter wide and about, and it'll be about 200 micrometers thick at most, about 100 probably, 100 to 200 micrometer biofilm.
Okay, so you don't think that that'll affect comfort in any way?
So, right. So the great thing about scleral lenses is at the center, you get about 400 micrometer thickness, but even at the periphery, you can design it so that you get 300 micrometer thickness in the post-lens tear film, 200, 300. So the way I will design it will be so that the lens fitting will of course be somewhat important, but so that it's thin enough so that you won't actually touch any part of the ocular surface.
I can feel a question from Dr. Corzine coming on here.
Okay.
we'll move on. Dr. Harris has raised a hand.
Thank you. Very interesting presentation and very interesting concept. Again, as a contact lens specialist, my concern is whether or not this thin film is going to affect the comfort of the lens and or the effect of the lens on the cornea. The idea of using a scleral lens makes a lot of sense because you do get vaulting from on different portions of it. My question has to do with how long would someone have to wear this lens to get the optimum release of the drug? And if that is just a limited number of hours, is it possible that these lenses could be worn overnight if they were extremely gas permeable?
So I think that's a very good question. And like the PLGA released study figure that I showed, you can release continuously for 60 hours nonstop. And like I think the biggest issue now is the material, like you said. Will you have corneal edema? Will hypoxia be an issue? I think once that challenge is tackled, I think you could be able to wear this overnight to do a continual treatment. I know for some very extreme disease eyes or immediately after surgery, I know people do wear scleral lenses overnight, but those are for very sick eyes. And I wouldn't recommend that right now with current permeability lenses, but with better materials, I think that's definitely possible.
Thank you.
Dr. Wilson, did you want to ask a question? You're just muted there.
Sorry. So as far as I know, that there is one issue with scleral lenses potentially, which is elevation of intraocular pressure because of impedance of the flow through the episcleral vessels, and particularly as some of the newer drugs are actually targeting that. I'm wondering whether you have some ideas of workarounds for that.
So IOP issue, I've actually read very conflicting results about this. And I think now this is relating more to my personal research side, but there's been multiple studies, or there's been some studies that's suggesting that IOP increases with scleral lenses, while there's been other studies that are saying there's been no difference with IOP with scleral lens wear or not. But I think the good thing about this right now is that at least I think the drug delivery itself is a treatment option. So I think these are meant for people that are really needed with treatment. So I think this alternative way might be better, but I guess you're right in a sense that if the glaucoma or if the IOP elevation is indeed true with scleral lenses, which I'm at a fence that I don't believe it because of my own observations when I did my IOP measurements, but some people have been seeing it. But if that is an issue, then maybe people with elevated IOP shouldn't be using these type of drug delivery lenses.
Thanks.
Okay, any other questions? Remember to please use chat if you want to ask a question, just put your name down in the chat and I can call upon you. Good. Thank you so much, Young. Really fascinating presentation. Well defended. Our next contestant is Jessica.
Let me just share my screen here. All right, hopefully everyone can see that okay. Hi everyone, thank you so much for taking the time to join us today. I am very excited to share with you my idea follow-up. Just for a little about who I am, my name is Jessica Liao, and I'm originally from Seattle, Washington, and I'm part of the amazing class of 2022. So before we dive into what follow-up is, I would like to share a little about what inspired me to join this competition. June 2020 was a pivotal moment for me as well as the rest of our nation. For months, we watched the COVID-19 pandemic disrupt and take lives with no end in sight. And although COVID is a threat to everyone, people of color have been hit especially hard. This showed, besides COVID, we suffer from another national disease there's no vaccine for: racial discrimination. As I began seeing my first patients during this wave of civil unrest, it was a really steep learning curve, not only in patient management and figuring out how to be a doctor, but in forcing myself to confront the uncomfortable truth of implicit biases affecting my practice. Taking another step back, I've always believed in the power of positive thinking, but 2020 made me reevaluate myself and how optimism and sunniness, it can blind you to the suffering of others. It is tempting to feel powerless in controlling national policy to address such disparities, but follow-up is inspired by my desire to provide patient-centered care that recognizes differences among various groups in terms of attitudes, access to care, and relevant cultural issues. And that brings me to this quote by Bill Gates, which I feel resonates deeply with my mindset in creating follow-up during a time where racial unrest in our nation has drawn accusations of hypocrisy and questions of democratic legitimacy. In his words, being an optimist doesn't mean you ignore the tragedies and injustice. It means you're inspired to look for people making progress on those fronts and to spread that progress more widely. So with that, what is follow-up? Follow-up is an automated, real-time patient registry software that aids providers to deliver custom support so patients understand their treatment and options for financial and social support. Once a provider enrolls a patient in follow-up, the program will follow patients to track treatment milestones and appointments. In patient care, there is a lot of value in human caring and willingness to make time. Computers right now are still very weak in those domains, which is why provider partnership with follow-up could be such a powerful tool to help free up time so we can provide that patient-centered care. First, the system helps providers identify patients who are not on track for treatment. When a patient misses an appointment, the system will alert the provider. It then offers suggestions to help discover or problem solve circumstances that created a potential barrier to care. And this process is a deliberate effort to convey the team spirit between patient and provider by enabling patients to play a profound role in developing solutions and foster patient-provider trust. Other key features of follow-up include, firstly, keeping an organized log. The patient registry makes it easy for providers or trained staff to note when a patient was contacted and the details of that interaction. This prevents confusion between providers and staff, as well as frustrated patients who may have been called multiple times by different office members. It also provides a clear timeline of events that we can refer back on to ensure that everyone is on the same page. Follow-up provides a proactive approach to exploring and responding to patients' social or belief-specific barriers with a database of suggestions on how to address common issues, such as financial concerns around insurance approvals, juggling family schedules, potentially inaccessible clinic hours, and common problems such as managing stress, pain, and other symptoms, all while staying mindful of racial equity. The system allows the provider to input notes, to record interactions, to encourage accountability and transparency. And it will also alert the provider if a patient does not come in for an appointment within a specified time range. Lastly, you can track treatment milestones and follow the full trajectory of patient care. Rather than blaming the patient for incomplete care because they may have no-showed their appointment, follow-up opens the door for building an empathetic relationship between patient and provider. This empathy requires collaboration between doctors and patients. It requires explanation, education, validation of the patient's feelings. And we know empathy and trust are those cornerstones that allow patient and provider to work together in being accountable for engagement and full communication in improving patient retention and health outcomes. Follow-up collects data of patient-reported experiences and outcome measures to facilitate an evidence-based approach to patient care. It also provides race-specific feedback on treatment completion rates. Although we are aware of physician bias and structural inequalities have resulted in decades of poor healthcare for people of color, we are also taught that racism is evil, so it's harder to recognize any of that kind of behavior, whether intentional or not, in ourselves. This quote here from Dr. Steven Pinkler, a professor of psychology at Harvard University, sums up why this feature is so vital to Follow-up's mission to reduce disparities in treatment. He says, the cure for these biases is numeracy. Numbers, after all, aggregate the good and the bad, the things that happen and don't. A quantitative mindset, despite its nerdy aura, is not just a smarter way to understand the world, but the morally enlightened one. It treats every human life as equal rather than privileging the people closest to us or the most photogenic. Follow-up generates feedback reports that help providers learn and take responsibility for understanding differences in terms of attitudes, beliefs, behavioral patterns, and cultural norms among populations of patients for which we are responsible for providing care. Racial and ethnic differences in acceptance of therapies and compliance with prescribed regimens deserves clarification. And differences across groups are unclear and may depend on the specific medical conditions, procedures, and prescriptions. The reasons for any differences also require study, whether they are due to differences in the way patients are treated or advised, in the cultural background of each patient, or in other factors. Follow-up can gather the necessary data to identify the causes of our problems in hopes of implementing the measures that are likely to solve them. Follow-up can be used by providers treating chronic disease across all medical disciplines, but it is especially applicable to our domain in which many of the diseases that we treat in optometry, especially, develop slowly and do not present with any early warning signs or painful symptoms. Glaucoma is a classic example of a chronic disease where permanent treatment and ongoing follow-up is critical. There are several ongoing studies examining ocular and genetic determinants of glaucoma in African American patients, but we must also look into social determinants that may be playing a role in eye health and glaucoma for racial minorities. Studies show that compared to patients with commercial or private insurance, Medicaid patients are less likely to receive commonly used tests to diagnose and monitor glaucoma, such as visual fields or optic nerve imaging. Moreover, Black and Hispanic patients had even higher odds of not receiving these tests compared to white patients. As doctors, we need to recognize that these inequities exist and strive to follow best practices and clinical guidelines of care, irrespective of a patient's race, ethnicity, or insurance coverage. With this knowledge, follow-up is a system put in place to point out these lapses in care, ensuring minority patients who are more likely to miss appointments and as a result are at considerable risk of vision loss are being kept track of. Ultimately, my dream for follow-up is to build a more culturally competent care delivery system to help people from all backgrounds feel there is someone there who cares about who they are, what they are going through, access to resources, and helping them break down barriers that are true to them. Thank you so much for your attention, and please let me know if you have any questions. You can also reach me through email or find me on the run to clinic. I'll be the one wearing a fanny pack. Thank you.
Thank you very much, Jessica. Great presentation. Judges, questions for Jessica? Jorge.
Well, Jessica, I have to commend you on bringing up this really important topic and the issue of compliance that is becoming a bigger and bigger issue, not just with populations of color, but everybody. It certainly affects underserved populations more. So congratulations for that. I'm really glad that you brought this up. And, you know, personally, this is something that's really near and dear to my heart as well. And, you know, as far as the work that we're doing with diabetes. So it's good to see this presentation here. Question though, in terms of, you know, the innovation and everything, do you see this more as a service or as software? Is follow-up a service that you're providing to patients, clinics, you know, other stakeholders, or is it a software platform that you would plug in into different places, or how do you see that evolving?
Yeah, thank you for asking that and for your comments. That's a great question, and I'm sorry I wasn't more clear about it during the presentation. It is a software that is going to be used primarily by providers. So it's for providers to have information on the patients and a database on how to help patients. So in my mind, the patients wouldn't directly be interacting with the software. It's the people that are using the software, and then they can reach out to patients. So this could either be a provider, such as a doctor, or even someone in the office that may not even have necessarily a clinical background, but the software provides them with that information and the resources to approach patients in a more inclusive and helpful manner. Hopefully that answers your question.
Well, you know, actually, it's difficult because if it's a software, then you're still depending on the operators, the clinicians to provide the interaction with the patients. But there's still some content in the software that will make a clinician, I'm just trying to understand, will make the clinician more sensitive, more more able to get the patients to comply with treatment, and be able to track their treatment.
Mhm.
So I guess, that part of it was a little bit unclear as far as where you're drawing the distinction between a repository, I guess a platform to teach people, to teach clinicians to be more sensitive.
Right. I think oftentimes we run into a wall as to thinking we really want to help this patient, but we don't necessarily know how. And so I think having that database of ideas that are very common, such as maybe transportation arrangements that are available to patients in the area, or information on services such as elder care so that people can come in for their appointments and have someone look after whoever they need looking after. I think it's more of having that database there that can be easily navigatable, so that providers can easily and efficiently provide information to help those patients so that they can feel empowered to get the treatments that they need and be seen by the doctor.
Thanks.
I guess just really building on Dr. Quadros's questions, one of the problems here is how do you combat the implicit bias of the clinician? So I really appreciate you quoting Steven Pinker, who's been one of my favorite philosophers for a while. And I believe he's right. Data is the source of equality in some way. It was the point he was making. But you do have to rely upon the clinician to want to improve or want to serve. And just wondered, how do you get at that implicit bias, the clinician who, I guess you wouldn't buy the app unless you wanted to. So you may be providing a service to the already converted, but I just wondered if you thought that one through.
That is a really good point. I think so far my idea does base it off the fact that in my community, a lot of us are trying to improve ourselves in this sense, but I know that that's not always the same across the rest of the nation. I guess my dream would be something like this would be required of practices to have, so that we have the data on how, if there are certain groups that are not being treated the same as other groups. So that would definitely be something, I think that would be my dream for it, but I totally understand where you're coming from, where it does take someone who is already very passionate about this to want to use this service.
Well, there's good news afoot. There's great strides being made at the moment on, right across the country. There is demands being made for compulsory continuing education on implicit bias and cultural competency. So, there is hope, and you would certainly be adding to that and bringing that to us all. So any other questions from the judges?
Sorry, one more thing I just want to elaborate on that is another thing that could, I think, inspire people or make someone more interested in this service is that follow-up does aim to decrease no-show rates of patients. And I think there are economic benefits to that because there'd be increased appointment attendance and then followed by increased reimbursement for services. So another draw of it could be for some providers, the fact that they're reducing the idle unbillable time attributed to those missed appointments.
Thank you. Austin?
I have a question. So very nice presentation, and
Thank you.
it's the kind of idea that sounds obvious. And when I hear an idea that sounds obvious, sometimes that means it's just a great idea, and other times it might mean that other medical professions have implemented something like this. it's hard. It seems like such a good idea that it's hard to imagine that smart people at Kaiser don't have something like this already. So what do you know about what's out there? What does this compare to? I mean, if you looked at sort of a market for, you know, what kind of market is there for this software? Are you competing with other companies?
As far as what I know, just based off of our clinic and then other clinics I've shadowed at, I think a lot of it comes down to the staff have to just be really on top of the patients that are missing appointments or on top of the scheduling and reaching out to those patients that didn't show up. So at the moment, actually, I'm not really aware of any exact technology besides just the old-fashioned method of booking appointments and you know, noticing there is a missed one and calling that patient to follow up to see what happened.
Thank you.
Thank you.
Garrett?
So I was just going to say, Jessica, these are really relevant topics to what we're thinking about at the Global Innovation Center at VSP. And some of our projects are in, you know, female health focus, gender fluidity, and, you know, just wondering, I mean, you spoke about different, you know, treatments based on ethnicities. I'm wondering if you could talk about maybe some disparities, you know, for females versus males or gender fluidity issues.
I actually didn't look into as much into gender issues, more so racial issues. But I would happy to elaborate more on that if you're interested. Okay.
No, I think you've done an excellent job actually speaking to that. I was just more or less trying to say these are areas that we care very much about. So I'm glad to see that reflected.
That's great. I think that's definitely something else that the software could be keying into and following and tracking. Because I think all of these statistics are very interesting because we don't often know if we are, you know, treating people differently because we like to think that we don't. So that's a great idea. Thank you.
Thanks.
Teresa?
So a lot of these questions around compliance, you know, I wonder whether patients are more likely to report the true reason for their non-compliance if they were questioned in an anonymous way. So if this service went out directly to the patient and there was some little pop-up that came up on their phone asking why they missed their appointment, you know, do we know whether that data is more accurate than what they would report to the clinician? Because, you know, many people don't like to disappoint their doctors and so may not really report their compliance accurately.
Yeah, that's a great idea. Another thing I was thinking about was how it's important for us to recognize that it takes a lot of health literacy to understand a lot of the things that we say during an appointment. And patients may be, like you said, either embarrassed or shy about explaining that they didn't really understand what was going on during that moment. And then coupled with the anxiety of dealing with whatever we diagnose with them with, I think the anonymous aspect is something that I think would really benefit. So thank you for sharing that.
Ron Kemper has a question.
Yes, thank you. I love where this is coming from. Absolutely. I think the focus of care on the patient side, on the just diverse and equity is so much needed. Austin had asked a similar question I was going to ask in regards to, are you aware of any other systems out there doing this? I can tell you from industry standpoint that there are several EHR systems that manage patient records and they will send auto emails out if you've missed an appointment and that type of thing. Of course, what's lacking is the compassion and the personal touch from those. But so my question to you is, would your system work in conjunction with these EHR systems, or would they be a completely separate product? And if so, how would you convince the optometrist that's spending money on their EHR system to purchase your system?
Yeah, that's a great question. Let me think about that for a moment. So I think it would be much more efficient to hook up follow-up to an existing EHR system, just because the patient demographics and all those things could easily be converted over. As far as convincing optometrists that this is something that they need to add to their system, like you said, there already are a lot of automated EHR systems out there that will contact a patient when they miss an appointment or something like that. But what I want to emphasize about my software or my idea is that human component of it. Because when we contact a patient using the software or using the suggestions coming from the software, we're actually speaking to them, and there are linguistic cues that come with someone's voice that suggest feeling and a certain way of thinking. And it means that we can connect to patients and get a little closer to what they're actually going through. So I think if you can talk to someone that currently already has an automated EHR system, like you can just ask them, how well is that really working for you? And honestly, at least from what I've seen, I don't necessarily think it's the most effective way to reach those patients. So that's the difference between what's currently out there and what I feel like I'm offering.
Thank you.
Thank you.
Especially if the EHR sends them a missed appointment bill. Yeah. Any other questions? Well, thank you, Jessica. We should move on to our final presentation from Bryce Olson, the Automated Display System and App.
Thank you. All right, let me share my screen. All righty. So, hi everyone. Thank you for spending your Wednesday evening listening to our presentations. My name is Bryce Olson, and I am a current member of the class of 2024. And today I will be introducing to you my idea for the automated optical display and corresponding app. So some context behind my idea was I've noticed that there's been an observable change in the way that patients purchase and select frames that has led to a rise in popularity of online optical retailers. This increase in popularity of online optical retailers can be contributed to probably many different reasons. One being that the access to healthcare is inconsistent and it's also expensive. The online retailers offer affordable and convenient services that are appealing to a lot of different patients. These easy, customizable, and cost-effective solutions are preferred over having to stand inside of the traditional optical. Additionally, novelties such as frame styling quizzes, virtual try-ons, and online promotions also can entice patients to go that route for purchasing glasses. Next up, the traditional optical retail experience is pretty dated. I began to think about what could persuade a patient to purchase glasses in person rather than online. And I also realized that the traditional optical retail experience has basically seen no change since commercial glasses reached like a marketable status at the turn of the 18th century. The majority of opticals are created using the same basic format, the basic layout, hundreds of frames displayed in a gridded pattern on a stationary wall. And this also presents issues for both the provider and the patient. From a provider's perspective, they want to offer their patients a wide scope of frames to accommodate their diverse patient population. However, an optical can quickly escalate into a disorganized maze of misplaced and crooked frames. Hours can go into reorganizing the optical after a busy day. From a patient perspective, frame selection can be frustrating and overwhelming, and patients do not always know which frames are right for them. When they're presented with so many options, it definitely can be confusing on which options proper for their own prescriptions. Another new consideration, that's one that I hadn't considered when I had first created this idea last year, was COVID-19. And one of the main things that opticals are facing now are patient to frame transmission of pathogens. The cleanliness of the frames is now a major consideration, and opticals are forced to establish a tedious and time-consuming cleaning routine to ensure the sufficient decontamination of their frames. Additionally, multiple people can not look at the same frame at the same time, and my idea will aim to remedy that issue. Again, to reiterate, proper optical and frame sanitization is necessary but time-consuming. So with all these problems in mind, the main question is, how do we bring the online retail experience to our patients? And that is how I came up with the automated optical display system and app. So my proposed solution is tasked with the responsibility of creating a modern, customizable, and sanitary retail experience. The integration of this system will eliminate hours of work that previously went into optical upkeep and allowing that same resources to be allocated back towards patient care. So a little bit of a design overview. The system would feature multiple interactive screens displaying the current frame inventory. Here's a closer up diagram of what the individual screens would look like. At the top, we see a camera for optional photo with frame on, which I'll go into a little bit later. The main interactive touchscreen display, and the frame dispenser with its corresponding indicator lights. Here is a more refined version of my diagram. All right, so moving on. The patient would begin by logging into or setting up a patient profile that's unique to them. Next, the clinician or optician would upload their newly updated prescription to their profile. The display would use the prescription information along with the patient preferences as a filter to present the most suitable frame options available. So here I am logging in. It's my amazingly safe PIN. And here's my profile. So different things that could be presented on the profile include age, almost quarter century old, prescription, insurance, and the types of frames that they cover, PD, etc., things like that that are important to consider when dispensing frames. Applicable filters that you can input into this software could be the brand, the pricing, material for people who have allergies or sensitivities to certain materials on frames, color, shape, the age of the patient, if you're looking for children's glasses versus maybe someone who's a little older, glasses suited for a patient's face shape, new arrivals, bestsellers, and things like that. After putting on the filters and finding frames that you like, you will be presented with the details regarding the frame that you selected. This can include the brand, price, insurance coverage, again, all of those things. Thanks to electronic inventory, the entire product description will show on the screen. And after browsing through the online screen, a patient would then have the option to add these frames to their favorites to look back on later. When they're considering many options, this can be a nice touch. And next, they also have the option to take a picture using this camera up here. So I click this button. So that brings you to this. If they are really feeling the glasses, they can tap the try on button and it will dispense this into the dispensing frame, or they can then physically try on the frame. And additionally, they can save the frame that they trade on to the app so they can reference it later. So while browsing frames, I have noticed that patients instinctively pick up frames without much thought. They kind of just browse, pick them up, put them back down. My display will decrease the number of times that frames are handled, which would subsequently decrease exposure to the dirt, germs, and damage that they can receive. To help replace the missing frames, the system displays a light indicating that a frame is present or absent based on the green and red lights, as well as another indicating light telling if the frame has been sanitized. So the app is a critical component to my idea, given that it brings the online retail luxuries directly to the patient while also providing a degree of cohesiveness and engagement with the frame selection process. So it only makes sense that as we become more dependent on the technology, we make efforts to implement it into the optical retail system. And it's an area that typically has not seen many changes. Again, by decreasing time on the phone, time in the eyewear center, more resources can be focused on the patient care. To go into detail of this app, certain aspects that it could have, let me go back one more, is you could check your order status on glasses that you had currently ordered. You could receive estimated pickup dates for those glasses. You could schedule follow-up optical appointments for adjustments or other sort of minor things. Browse frames prior to your appointment, view photos of frames you liked while at the office, and access your own personal prescription information. So in conclusion, the main goals that my display and app are aiming to address, one moment, my screen locked, is increase optical revenue. So this will bring the benefits of online retailers into the optical system. Next, I want to enhance cleanliness and organization of the optical system, streamlining the retail experience by implementing this technology. I want to save time to focus on patient care. The implementation of this automation will allow for more time focusing on the patient. And finally, keep optometry current with the rapid advancement in technology. So with that said, are there any questions?
Thank you, Bryce.
Thank you.
So judges, questions for Bryce. I can kick it off while we're going back to the other screen. You know, one of the things that you mentioned there was face shape. I also like the idea that they might be able to go into the system before even coming in. Mm-hmm. But what seemed to be missing was that important thing about giving options, you know, giving advice. I think, you know, a lot of people, if you ask them what their face shape is, they maybe wouldn't even know.
Right.
And, you know, starting to work out what different types of frames. I mean, you know, a typical dispensary might have 1,200 frames, of which 30 might work for a given individual,
right?
Maybe 50. But, you know, how do you get down to that choice? And is there a way that your system could actually help narrow the choice and then give options that you can hone down to the most likely pretty quickly?
Right. So I guess my idea does not eliminate the need for an optician completely. If anything, it'll augment the relationship between the patient and the optician, initially working together to narrow down their preferences and then allowing them to browse the frames after inputting those preferences into the system. So that way the patient isn't going in blind with no idea on what they're looking for still. They'll have the input from the optometrist or the optician to help them kind of guide their decisions, along with the automation of the system itself.
I like Vernon's comment. He said, instead of Gucci, it would be Groucho. I was watching. Judges, any other questions?
Okay. So this is, you know, always good to be able to improve the efficiency of the opticians. But how would you maintain the content? You know, it seems like a huge task to to maintain all of the things that you have in the app about each frame.
Mm-hmm.
Yeah.
So the way I was thinking of it was there will be an input of the electronic inventory into the system that either the optometrist, the optician works to upkeep. They input the new frames, get rid of the old ones, and that's displayed on this system. So there is some background work that would go into prepping the screens. It wouldn't completely be automated. You still have to upload what's specific to your own practice or your own optical. And I guess basically, let's see if I stopped sharing my screen. I lost my train of thought on that one.
So, so then the opticians, the office would be putting in their own descriptions, these glasses are good for disguises or for, proms or
Yes.
job interviews and stuff like that. That would be generated by the opticians themselves.
Right.
Or
They're,
okay.
Yeah, the people who are trained will input their information in. And I think that this way, it won't be completely the patient going in and trying to decide for themselves what's going on. And yeah, basically, yeah, that's a good question.
Okay.
So I got a question about the logistics of this.
Yeah.
So let's say you wanted to build a dispensary where it was all these automated optical displays. So would there be one? Would there be 10? If there was one, would they wait in line? And if there were 10, is there one big robot behind the wall that's putting all the glasses in the drawers that they pull out?
Right. So I guess that would depend on the size and the flow of patients in their individual opticals. For a smaller private practice, they might want to purchase one of these optical frames because they have a smaller frame selection, or they could have larger, say even like Berkeley's hospital, in their eyewear center, they could have multiple walls because they have so many frames to choose from. And I think that the degree of implementation would depend on what the optical's current needs are. And to go on the second part of your question, there is some personal upkeep that would have to be done. If frames go out of style or are discontinued, the optician or optometrist could remove them from the system. The way I think of it is kind of like almost like a vending machine. All these frames are somehow organized within the back of this system, and the proper frame is pulled to the dispensing drawer when needed. So there is some organization that goes on behind the scene, but overall it should be way more streamlined than what it currently is.
Thank you.
Any questions from the audience? Wonderful. Well, thank you, Bryce.
Thanks.
That's the end of our presentations, end of our questions. If you will now just excuse the judges for a few minutes, we'll just head out to a little breakout room, and we'll be back as soon as possible to announce the winner.
Now that they're gone, whew. Man, I gotta tell you, this year produced a good set of presentations. Looks like we ran the gamut. I mean, we got provider equipment, drug delivery systems, software, the optical with an app. I mean, the diversity just alone and the amount of information that you were able to compress in 10 minutes each was really remarkable. And I commend each and every one of you. And
absolutely,
it's nice to be on this side while they figure this out, because I want to say, you know, whoever is selected, essentially, you know, they won the competition, but, you know, take your ideas to the next step, right? I think this is one of many competitions, right? Don't think of this one and done. This could be more. You can continue to evolve this. So do not be discouraged in any of the outcomes that, you know, you were thinking you might go your way. You know what I'm saying?
Yeah, thank you for that. I think we all were really, well, for me, I was just very impressed with everyone else's talk today. So I really enjoyed listening to everyone's talks. And I think this is a great platform to really get to know about other people's great ideas. So thank you for the opportunity.
Yeah.
Really means a lot. Thank you, Brendan. Really appreciate it.
Yeah, to add to Vernon's comments, I think every one of these presentations has legs, so let them run. You know, don't let it stop just because whether you win or not tonight, follow your dreams and pursue these, absolutely, because they do all have some meaning and purpose to them.
So were you guys nervous? Did you guys practice a lot for this?
I was especially
I'm always nervous.
I got even more nervous when Dr. Harris showed up.
I'm always nervous. That's a good one.
Yeah, so this was just, added extra, a little more nervousness than usual.
Your PowerPoints looked really good, or your decks. I mean, good stuff all the way around.
Yeah, I wanted to say that too. Like I realized my PowerPointing style has just been so antique.
I had to compensate for my nervous public speaking habits by making good slides.
Oh, everyone's slides were so good. Like, I'm just baffled. I think I need to go learn how to make PowerPoints or slides better.
Well, you're in school to become doctors, not PowerPoint presenters.
There's a lot of really great resources online, Young, where you can find templates that people actually offer for free because they know that not everyone is really strong in this suit, but they want people to be able to share their ideas in a more aesthetic manner.
Oh, neat. I'll definitely look into that.
I'm getting nervous for you guys and excited at the same time. Someone needs to talk because I can't stand silence. Or if you want to play music or something, because if I sit alone with my thoughts, it's going to be pretty bad.
I tend to dry cough a lot when I'm nervous. And I was doing it before the presentation. My girlfriend was like, "Do you have symptoms?"
Yeah, I think I was more nervous about this thing, giving talks at conferences. I don't know why. I felt more nervous today than I did like at Arvo last year. Or it's kind of interesting how it works. So,
what your thesis defense is going to be like?
So funny. I think thesis defense in our department is discretion of the committee members. So if they don't think it's warranted, we don't actually do a defense. That's my understanding. So.
Ron, Vernon, given that the Vision Expo East might still be virtual this year, is there an opportunity for the winner to present this at any type of gathering or something? Because, these are all very novel ideas and we'd love them to represent Berkeley, of course.
I don't want to put Garrett on the line here, but we have historically or traditionally offered to bring the winning student up to Sacramento with our what used to be called the shop, our innovation hub. Now we have repurposed that, and it is now the Global Innovation Center, which Garrett is representing. So not to put him on the spot, but we could certainly throw that idea to him. Unfortunately, we missed that opportunity the last 2 years because there was a window of time where the shop was under, a kind of a remodel, if you will. And so the last 2 years, winning students missed that opportunity. But Garrett, obviously being one of the judges right now, he's not hearing all of this. But it's a conversation that Vernon and I can take back with him because just from my perspective, I would love to bring that back again and bring that tradition back to the surface again.
Gentlemen,
yeah,
as I mentioned,
we'll find a way. We'll do something.
This is Michael Harris. As I mentioned in my chat, I may be the only one on the Zoom call who actually knew and worked with Rick Bay. Just a terrific guy. Wonderful sense of humor, devoted to the ophthalmic industry. I worked with him on a number of publications and CE programs. And as I mentioned in the chat, he would be absolutely delighted with these presentations and with what VSP is doing in his memory. Thank you so much.
Thank you for that. Yeah.
Thank you, Dr. Harris.
Yeah, thank you, Dr. Harris. I didn't know Rick Bay, and he was described to me when my meetings with Jobson and how this innovation legacy would live on. And so, when they told me about it, I was like, deal, easy. Who can I talk to? And then UC Berkeley, it was right around the corner. So it was just a great, easy implementation. The faculty, the school was tremendously welcoming and easy to work with. And I mean, you've taken it to another level because all of the schools have autonomy to kind of take it. And meaning that we also do this with another school, right? And other organizations do it with other schools. But I think UC Berkeley, you have a process in place. We're making something. This is something from now on, right? I don't see our support going away anytime soon, right. And it's growing as well. So, it's a relatively new scholarship and one that we want to continue to grow year after year. So just love the participation again. Thank you, Dr. Harris, for that background.
We really appreciate this. It's a great benefit to our students, and it's lovely for them to be able to showcase the talents that they have outside of just being optometry students. I was amazed at some of the presentations. It's just unbelievably thoughtful and creative. And thanks again for your sponsorship.
Pleasure.
Well, that was a wonderful conversation to drop back into. So thank you. And thanks again, VSP. The judges were really impressed this year. It's been a similar team throughout the years we've been doing this now. And the judges did want to pass along that they felt this was the uniformly highest standard that we've had in the competition so far. So really well done, everybody. I would like to add that on an inspiring day and a hopeful day and an optimistic day, you have also brought optimism and inspired us with your presentations tonight. So thank you very much. Greatly appreciated. We were unanimous in our decision, and that is that Peter G. will go on and represent us at the next stage. So many congratulations, Peter. We're very proud of you to be our winner tonight. Thank you again, VSP, for your sponsorship. We literally couldn't do this without you. And for the biggest audience we've ever had for this competition, we keep on proving to ourselves that not everything about these virtual meetings is horrible or a failure. We definitely get better turnout for these evening events for things like this. So that's got to teach us something as we hopefully crawl our way back to a normal society as this year continues. But thank you, everybody. Really appreciate you spending your evening with us. I know the students in particular and the presenters appreciate that support. And many congratulations. Thank you.
Thank you, everyone. I just want to say it really does mean a lot to have this opportunity to be here and to be the winner. I honestly wasn't expecting it at all. Just a quick background, I submitted an idea last year and it wasn't even accepted to be one of the finalists. So coming back here this year with the new idea, and I think winning this competition, it really does mean a lot to me. And I won't disappoint all of you moving forward with this project.
Oh, we're in California. We love recycling here. So recycling old ideas is always acceptable to us.
Wonderful. Well, good night, everybody. Again, thanks to our guests from VSP for joining us and for sponsoring. And we look forward to seeing your successes. And just the other contestants, the other finalists, if you would like to discuss your ideas with any of the judges, would all be happy to do that. So it was, as I say, inspiring all the way through. So thanks again. Good night, everybody.
Thank you, everyone. Good night.
Good night, Jessica. Oh, and thank you, Annie, for organizing.
You're welcome. Thank you.
Peter, you still there? Oh, he just took off.